today is a very, very special podcast with Cesar Rodriguez from New York at Mount Sinai, myeloma specialist, and we have like a very few minutes to bring the hot topics from emo and myeloma. You just gave a talk on myeloma and bispecifics, and we would like to, resume, the past indications for these bispecifics and what has changed in the last 2 years that we came from the last edition.
Sure. So the bispecifics here in Brazil were approved for people who are triple class exposed, which gives us the opportunity to use, whether it be teclistimabe, atual, or elranatamab, which are available here in Brazil, as soon as first relapse. Or if they didn't receive an anti-CD38 like daratumumab or isatuximab at first line, and they relapse, the best thing is to do a regimen that has that anti-CD38 so that the patients can then be triple class exposed, so that if they do relapse again, they can qualify for a bispecific. We know now that the Majestic 1 that is matured now and average 30 months follow-up, that those patients who receive therapy in earlier months, instead of waiting for heavily pretreated, they have a better overall response rate and they have a deeper response. It's not just the response that's important. The side effects are also fewer when you give the treatment earlier instead of waiting for multiple lines of therapy. So the infection rates, the neutropenia, the thrombocytopenia, and leukemia is less in all of those patients who received teclistimabe in third line or fourth line compared to that who had more than 5.
So we are kind of lucky in Brazil to have this approval, right?
Yes, you are very fortunate to have that. And now the question is, you have access to 3 bispecifics here in Brazil, and you're going to soon have access to an antibody drug conjugate, and you also have access to CAR-T, cilta-cel. So how do you choose which one? And the way cilta-cel is approved at first relapse, it also starts to come up conflict of should I do CAR-T or should I do a bispecific?
$1 million question, right?
And I also have one question about the response that we talked about. That with tech, we have a very quickly, and it's not just with tech, but with all the bispecific, we have a quickly response, but with tech, we show that we have a quick response, and then the response goes deeper, and we could see this response improve along the time. So, how long do you wait to change the cure? Say, okay, tech is not doing well, so I need to change the therapy.
We see the first response after the first cycle. So you're going to have a sense within the first 2 cycles if these patients are going to respond to teclistimabe. The maximum or the best response on average is about 4.5 months. If we give the teclistimabe in earlier lines of therapy, we're seeing the maximum response monotherapy. So when is it a good time to say this patient is not going to do well with teclistimabe, we need to change therapy? There's no guideline based on the Majestic 1, but based on my personal experience and commercial use of teclistimabe, since we've given teclistimabe in more than 200 patients commercially now, is if at the end of the second cycle the patient is not showing a partial response, that patient is not going to respond to teclistimabe and they're going to progress fast. So at that point I decide, am I going to switch to a different therapy or am I going to add something to the teclistimabe to get a better response?
And one thing that is very interesting, for which patient teclistimabe won't be your option, your choice.
And also, you show that now, in your experience, we have more than 90% of patients that not fit the inclusion criteria of the older clinical trials. So which patient you think tech is not an
won't be like, no, for this patient, I won't choose.
There's very few patients I will not offer teclistimabe. Somebody who has frequent infections because they because they have uncontrolled diabetes and they have diabetic ulcers, and they are not responsible with their health. Those are the ones I will not consider disease. But it could even be somebody who has emphysema, but is very well controlled or responsible and going to the pulmonary doctor and taking care of this disease. I will still offer teclistimabe because I know that that is a responsible patient. And I know that that patient is going to do everything possible to reduce the risk of infections. If it's somebody who I know is not going to be following instructions properly and has a high risk of infections, those are the ones that I'm going to doubt whether that teclistimabe is the best for them.
And this is a very important point because, like, this is the patient that has struggled with much of the therapies, right? And one thing that has changed a lot in the last years is IVIG. And actually, I was talking to you. IVIG was one of the things that I studied at Memorial Slow Kettering after rituximab and hypogamma and everything. And this has changed a lot and came a lot for myeloma because of the BCMA. And in your practice, are you using more IV or subcutaneous? And how do you manage like the IVIG every month, every 6 weeks, or it's individually?
We are using more the intravenous IVIG, but I don't think there is a difference between IV or subcutaneous. As long as you're administering the immunoglobulins on a regular basis and trying to keep the immunoglobulin levels above 500. Right now, our protocol has been to give IVIG on a monthly basis. But we are learning now that monthly is not necessarily the best dosing, and we need to individualize in the patient. If they're having a good response to the immunoglobulins and they're maintaining the immunoglobulins above 500, you don't need to be giving it monthly. But then there's a small percentage of patients that even though you're giving them immunoglobulins, they keep their immunoglobulin level very low and still have the risk of infections. And those patients, you either want to give a higher dose or increase the frequency of the IVIG or subcutaneous.
And talking about the infections, could you tell us about your experience with the CMV?
CMV reactivation is something that can happen with immunotherapies. And we always test for CMV and hepatitis before we start somebody on teclistimabe or any Biespecífic. If they have no CMV detected at the time of screening, I will not be monitoring for CMV during the remainder of their treatment, but will consider testing for CMV if they're having a diarrhea that is unexplained or a respiratory infection that did all the other tests and everything came back negative, then I'll check for CMV. Because the problem of checking serial CMV in somebody who is asymptomatic is that you're going to have some positive values, and it doesn't necessarily mean that you need to start treatment for CMV or that you need to hold that treatment. And those few patients that have been positive for CMV and are having some symptoms of CMV, we treat the CMV with the antiviral therapy, we follow the bispecific, teclistimabe in this case, and then once the CMV goes back to zero, we restart, and we haven't had anybody really activate after that. So that's been a very positive thing for our patients. But that also tells us that when we restart the therapy, if the disease is controlled, we space out the frequency.
So, the last question about the future. How do you see the use of bispecific in the future now that we have many options in combination?
How do you see the future? If you can project, how can you see like these combinations?
If you have a crystal ball.
Yeah, I can say that teclistimabe is going to move to the front line and it's going to be part of the induction. And if you didn't get it during the induction, it's going to be with the Majestic 5 and with the Majestic 4 showing excellent responses with the MRD immune activity that is sustained in all of those patients that are evaluable. It makes sense. Immunotherapy is very effective. It's it's more effective when we give it in earlier lines, and it is also more effective when you have very small amount of disease to treat. So I think the way that Hema took the cane and now is the front line,
I would say so.
it's going to the same thing is going to happen with the teclistimabe.
We're very, very happy to have you, and pleased. Thank you very much for like this minutes. And we know that you're very busy, so thank you.